Hey everybody, so we're going to be discussing the assessment and management of patients with diabetes, specifically DKA and HHS. Here's our list of objectives. Like I said, be sure you're familiar with these. These are what you'll be responsible for exams. Okay, so just a quick recap on these first couple slides. Are going to be recapping diabetes in general. You should be vaguely familiar with this coming from second semester. I know they do discuss diabetes. So diabetes is a group of diseases characterized by hyperglycemia caused by deficits in insulin secretion, insulin action, or both. Here's a fun little cartoon that I like about diabetes. So, like I said, Homer always loves eating the candies, and I wish it had donuts, but it's candies. They're made of sugars. Sugars are in the system. They're in his bloodstream. The glucose levels are too high. Can't help. Pancreas isn't producing insulin. So then Homer is now hyperglycemic, meaning that blood glucose is too high. And so he's hungry and really thirsty, and he's always having to go pee again. So just kind of a quick, comic version of that. Some long-term complications, blindness, end-stage renal disease, non-traumatic lower limb amputations, peripheral neuropathy. Basically, you're going to have that. You're going to lose sensation in your limbs as the disease process progresses. Major contributing factors is major contributing factors to heart disease, stroke, hypertension, and high cholesterol. So when basically how insulin works, just in case you've forgotten, when a meal is eaten, insulin secretion increases and moves glucose from the blood into the muscle, liver, and fat cells. Once in those cells, insulin has the following actions: transports metabolites glucose for energy, stimulates storage of glucose in the liver and muscles. Glycogen signals the liver to stop the release of glucose, enhances storage of dietary fat in adipose tissue, accelerates transport of amino acids into cells, and inhibits the breakdown of stored glucose, protein, and fat. Here's just a quick little diagram on how glucose works. So you got your insulin receptor. Once that plugs in, your glucose can enter the cell. Type 1 diabetes is insulin production is absent or decreased. So basically this is because of autoimmune pancreatic beta cell destruction. So basically your pancreas is no longer able to produce insulin. So these are results in decreased insulin production, unchecked glucose production in their liver, and fasting hyperglycemia. Affects 5% of adults with diabetes, and it's originally was considered juvenile diabetes, because typically children were the first one, the younger population is where they were first seen. So the thing with type 1 diabetes is it does require insulin from an outside source to sustain life. Without it, the patient can develop DKA, or diabetic ketoacidosis. If the concentration of glucose in the body exceeds the renal threshold of glucose, usually 180 to 200 milligrams per deciliter, the kidneys may not reabsorb all the filtered glucose. So when glucose appears in the urine, it's glycosuria, and that's where the excess glucose is secreted, and actually pulls with it excessive fluid loss of fluids and electrolytes. This is called osmotic diuresis. So that's going to be your polyuria, right? Insulin resistance is, type 2 diabetes is going to be your insulin resistance. This is going to be impaired insulin secretion. So it affects 95% of adults with diabetes, onset over the age of 30 years, increasing in children related to obesity. And it's slow progressive glucose intolerance. It may go undetected for years. So basically your body quits being able to, the insulin is still being produced, your body is just not utilizing it properly. Insulin resistance can lead up to metabolic syndrome, which is the name for a risk of factors that raises individuals' risk for heart disease and other health problems, such as diabetes and stroke. Metabolic syndrome, increased risk for type 2 diabetes, is elevated glucose levels, abdominal obesity, elevated blood pressures, high levels of triglycerides, and decreased HDLs. So consider a patient with 3 of 5 of these components considered to have metabolic syndrome. Despite impaired insulin secretion, the impaired insulin secretion that is characteristic of type 2 diabetes, there is enough insulin to prevent the breakdown of fat and accompanying production of ketone bodies. We'll talk about this with DKA. But so basically, the thing with type 2 diabetics is, although they're not able to utilize all the insulin they need, they're able to use some of it, which is usually enough to keep them out of ketoacidosis. So DKA does not typically occur in type 2 diabetics. It can be seen in people with type 2 diabetes in conditions of severe illness or stress, and when the pancreas cannot meet the extra demand of insulin. For example, when you're ill, your body does need more energy to recover, or when you have injuries, and when you're stressed, your fight or flight, you're going to need more sugar. Your body's going to produce more sugar, and you're not going to be able to. Your body's going to need more energy, so you're going to start breaking down that regardless. Type 1 risk factors for type 1 diabetics is going to be early onset, familial, genetic predisposition, possible immunologic or environmental factors. Type 2 is generally obesity, age, previous identified impaired fasting glucose tolerance levels, hypertension greater than or equal to 140/90, HDL less than or equal to 35, or triglycerides greater than 250, or a history of gestational diabetes or babies over 9 pounds. Some clinical manifestations. Everyone should know the 3 Ps of diabetes: polyuria, polyphagia, and polydipsia. Fatigue, weakness, vision changes, tingling, numbness in hands and feet, dry skin, lesions or wounds that are slow to heal, recurrent infections. These are all, like I said, these are all things you should be kind of familiar with that comes from the diabetes lectures that you've previously had. Type 1 diabetics may have a sudden weight loss as well. Some diagnostic findings: fasting blood glucose greater 126. There's a casual glucose equal to or exceeding 200 milligrams per deciliter. And chart 51.2 is a good chart for diagnostic criteria. And this is this chart right here. So some complications of diabetes is hypoglycemia, so low blood sugar. That is a complication because as you treat it, you're going to give yourself insulin or your oral medications to help you utilize insulin. So you do run the risk of hypoglycemia, of using too much of your blood sugars. You can go the reverse of DKA, that's diabetic ketoacidosis, or HHS, which is the hyperglycemic hypermodular syndrome, or I'll be calling it HHS now on. Comparison, and there is a table 51.7 is a good comparison of DKA and HHS. So DKA is a metabolic derangement that results from a deficiency of insulin. So, the way to break it down, if we've talked about it through other lectures, is, there's basically your body is an absence amount of insulin resulting in abnormal metabolism of carbohydrate, protein, and fat. So your body can't utilize glucose like it normally does, so it starts metabolizing carbohydrates and protein and fat, and those are forming ketones, which are highly acidic. And as they build up in your bloodstream, metabolic acidosis occurs. There's your diabetic ketoacidosis. 3 main causes of DKA are going to be decreased or missed uses of insulin, illness or infection, or undiagnosed and untreated diabetes. A lot of the younger patient population, as they come in, that's how they find out they have diabetes, is they come in DKA. They didn't know it, and next thing you know, they're they come in DKA. DKA might be DKA might be, like I said, is the initial manifestation of type 1 diabetes. Other precipitating factors is going to be illness, poor self-management, neglect, patient error, drawing up the wrong insulin, equipment problems. A lot of diabetics that require insulin will be put on an insulin pump. If there's an occlusion in the pump, we've seen those where they're not in there. Improper insulin storage. We've had patients coming in for DKA because they left their insulin on the kitchen counter and their house wasn't cooled by, it was swamp cooler, so it still got really warm. The insulin that he had was denatured, so it made it basically ineffective. So he was giving himself ineffective insulin and he went into DKA. So, taking care of the insulin properly, illness and infection where you need extra sugar, all those things. Commonly preceded by a day or more of polyuria, polydipsia, nausea, vomiting. These are some of the signs we talk about. The DKA, the metabolic acidosis. You have the vomiting, fatigue, and eventual stupor and coma if not treated. So, if you think of what's happening with diabetics is as you're one, the acidosis can cause that as well. Also, what happens is your body is basically dehydrating, because if your bloodstream is full of glucose, your by osmotic pressure is going to pull more fluids into it, which around doing basically dehydrating the cells around, and including your brain and other areas, so you can start having superimpossible coma if not treated. They do have a presence of a fruity breath if they're in ketoacidosis. Some clinical features: you're going to have hyperglycemia, you're going to have dehydration, electrolyte loss, and acidosis. 51.7 and the sick day rules are good things to review. 51.7 is kind of the pathophysiology of DKA. Kind of just gives a quick breakdown of it. It's a good way to look over it. And then without insulin, the amount of glucose into the cell is reduced. And then the production and release of glucose by the liver is increased. Liver is stimulated. So what's happening is, like I said, your body is not utilizing sugars. And so what happens is, well, your cells still need energy. So they basically then your liver is then stimulated to increase more sugar, even though it's not getting it. So that's how you just keep increasing glucose. That's how your blood sugar keeps increasing, leading you to hyperglycemia. Additional glucose can't be used. That's when your glucose rises. Osmotic diuresis is the body's attempt to get rid of that. And then as your kidneys excrete your sugars, it's going to reduce. You're going to lose water and other electrolytes, causing dehydration and electrolyte loss. In extreme cases, over a 24-hour period, patients can lose up to 6.5 liters of water and 400 to 500 milliequivalents of sodium, potassium, and chloride. So, dehydration is definitely a severe thing to be worried about. In an emergency situation, initial goal of therapy is to establish with a patient when they first arrive, the first thing they get is 2 large bore IVs, and they're going to begin fluid and electrolyte replacement. So, untreated, like patients become comatose as a result of the dehydration and electrolyte imbalance and acidosis. And we talked about earlier, if your body can't get sugars from, using insulin, it's going to break down fat stores, and that's how it receives the ketones. And like I said, there are acidic byproducts of fat metabolism, decreasing your pH, causing metabolic acidosis. That's the process with that. As your body is related to illness and infection, emotional and physical stress can increase your blood glucose level, resulting in hyperglycemia. So your body increases stress hormones, glucagon, epinephrine, norepinephrine, cortisol, and growth hormones. And by those, it's going to increase your blood sugars as well. Patients with type 1 diabetes may need an increase in insulin to prevent DKA. So rule of thumb is, when you have patients that are ill, if they're diabetics, to try to stop them from getting into transitioning into DKA, you're going to have them increase their insulin dosing. Actually, it's a sick day protocol. So if they start having ketones in the urine, you need to increase the amount of insulin they get for each of their meals and whatever their standing orders are. The one thing you don't want to do is you don't want to decrease the insulin dose to compensate for decreased food intake or nausea and vomiting. Because like I said, if you're ill, you're nausea and vomiting, your body's still producing sugars even if you're eating or not. You're still going to follow the same regimens, checking your blood sugars and giving your insulin doses as needed. You never eliminate insulin doses when nausea and vomiting occur. Okay? So you're still going to follow, usually, general rule of thumb I know in the hospital we use is you're going to take a urine ketone, and ketones can come everything from none up through high. So anything that's large or moderate. So anything that's moderate, you're going to take whatever their insulin dose is and multiply it by 1.1, which will give them a slight increase of insulin. And if they have large amount of ketones, you're going to multiply that by 1.2. You're not responsible for that, just so you understand that even in the hospital, if people come in DKA, that's how we're going to do it. We're going to give them increased insulin doses while they're working through their illness. You are going to want them to keep attempting to eat small portions of carbs, drink fluids every hour to prevent dehydration. You're going to, it's like this is if they're at home, assessing every 3 to 4 hours. Pretty much if they're going into DKA and they have ketone, they're spilling ketones in their urine, you're going to want to check every void if they have ketones or not, because that's how you're going to help them move through the disease process. Here's some patient education about sick day rules. It's interesting to read. So some clinical manifestations. We've talked kind of about DKA, dry mouth, the same polydipsia, polyuria, fatigue, blurred vision, headache. And then you're going to have, as they become dehydrated, you're going to have orthostatic hypotension, rapid weak pulse, right? These are all things you would expect to see with someone who's dehydrated. With ketoacidosis and the ketones and the acidosis of DKA can lead to GI symptoms, anorexia, nausea, vomiting, abdominal pain. We kind of went over these with your metabolic acidosis. Like I said, the acetone breath, so it's going to have a ketone smell, a fruity smell to them. We talked about this in our respiratories, right? Your ABGs. What do you do when you start having metabolic acidosis? It's the rapid, deep breathing, which is Kussmaul's respirations. This is where it all comes from. See, it all comes back to you eventually. Mental status may wildly vary, gradually increasing restlessness, confusing. Patient may be alert and lethargic or comatose. So it all depends on the patient and how they're responding to the current situation they're in. So kind of have to just be ready for everything. We talked about this. Kussmaul respirations represent the body's attempt to decrease the acidosis. This is all from your respiratory trying to relieve CO2 to counteract the ketone buildup. While in the hospital, you're going to monitor ECG for dysrhythmias, including abnormal potassium levels. So we talked about that, right? If you're, how do you say this, right? So if you're going into acidosis, what's your body doing? Your body is going to be absorbing. It's going to be absorbing the hydrogen ions and releasing potassium in exchange. So that can change your potassium levels. You're going to be having polyuria. So you're going to be voiding, and you're going to be voiding out a lot of your potassium as well. So you're going to be checking those things. You're going to follow that frequently because your heart rhythms could change drastically. You're going to be doing, if they're in with DKA, usually it's hourly vital signs, fluid volume status, so it's frequent I's and O's, frequent ABGs, usually mental status, neurologic status. This is going to be frequently Q1. Generally, patients, depending on the severity in DKA, will be in the ICU. Frequent lab values, usually Q1. Checking your ABGs and your and your blood sugars and your electrolytes. Blood glucose can vary between 300 to 1,000 depending on the degree of dehydration. Some patients have lower glucose values. So the severity of DKA is not only due to the blood glucose level. So it's not, someone in 300, with a 700 blood sugar may not have the same pH and being as bad of a ketoacidosis as someone with a pH of 350. Everyone responds differently to it. So, ketoacidosis is a reflection of a low bicarbonate, right? Low pH, right? So and then low CO2 reflects if their CO2 is low, it's basically because they've been working, they've been doing the Kussmaul's respirations to try to compensate for it. So as ketones bodies build blood and urine, electrolytes vary according to the degree of dehydration, increasing creatinine, hematocrit and bun. If not treated, the patient will develop severe depletion of your electrolytes, sodium, potassium, chloride, magnesium phosphate. Eventually, hypovolemia followed by shock will ensue, and renal failure can occur from hypovolemic shock. Remember your renal lectures that your kidneys do need a certain volume to be able to function properly. So if you're hypovolemic, that could cause severe renal damage as well. So your initial treatments: rehydration, IV fluids, IV continuous infusion, and you're going to have a continuous infusion of insulin. So your goal is to reverse acidosis and restore the electrolyte balance. Rehydration needs you need to watch as you increase your value. We were talking about if your body is absorbing hydrogen and releasing potassium, and as you rehydrate and your body's acidosis is resuming, you're going to lose your potassium levels are going to go down. So you're going to be doing frequent monitors of your potassium. And remember, insulin enhances the movement of potassium into the cellular fluid. So you're going to, as you're giving them insulin drip, you're going to be moving more potassium as well. So there's two things there now that are going to be shifting potassium back into the cells and out of your blood, causing increased risks for hypokalemia. So monitor blood glucose, renal function, urinary output. You're going to have ECG, electrolyte levels, lung assessments, and vital signs for fluid overload. Because if they have cardiac problems, you can't, as much as you want to rehydrate, if they're in heart failure, a certain amount of it, you could run the risk for fluid overload in the process too. It is possible, because if they're losing between up to 6.5 liters in a day, they can need 6 to 10 liters of fluid to, for proper rehydration. Initially, you're going to be normal saline, given at a rate of half to a liter per hour for 2 to 3 hours, and then transitioning to half normal saline, for especially if patients are hypertensive, hypernatremia, heart failure, right? Because you want to keep the sodium down if possible. Then you will eventually transition to half strength normal saline regardless, depending on, and it's going to be at a high rate depending on their dehydration, up to 200 to 500 mils an hour. And then as your blood glucose levels reach 300 mils or 300 milligrams per deciliter or less, you'll change to a dextrose D5 with water to prevent the sudden decline of glucose levels. Because as you're giving insulin, dropping in blood sugars, you don't want it to drop too far, right? Because you can go in hypo. Then you can have hypoglycemia, where you go the complete other direction. And you don't want to drop too much, because then if you drop too fast, if you drop your blood sugar too fast, you run the risk of cerebral edema as well. Because like I said, as you were dehydrated before, as you rehydrate, if you rehydrate too fast, you could injure the patient in the process. So frequent, like I said, with rehydration, frequent vital signs, lung assessments, eye, nose. Like I said, typically it's it's strict eyes and nose, so that's usually Q1 every hour. You're monitoring those as well. Potassium is a major electrolyte of concern during DKA. So initial potassium levels can be low, normal, high, depending on where you're at in your acidosis. So serum, you need to monitor them frequently. Some factors that affect your potassium: you got your rehydration, as like we talked about that earlier. As it increases your plasma volume, you're going to decrease your overall potassium that way, and leads to increased urinary excretion of potassium. So insulin administration, like I said, moves potassium in cells as well. So you just got to, I guess the whole point of these last cells is you got to monitor your potassium levels as you're doing your treatments for DKA. Potassium replacement must begin once. So right away, most times you'll have fluids running with electrolytes in them, including potassium, to help balance out the losses. Potassium replacement is withheld if hyperkalemia is present, right? And the patient is not urinating, right? Because if they're not urinating, they're not avoiding out the potassium they have. And if hyperkalemia is present, right, you don't want to give them more if it's there. So it still requires monitoring. You're still going to be monitoring frequent ECGs and laboratory measurements of potassium. So this almost feels like a fluid electrolytes lecture, right, with your potassium. Reversing acidosis ketones, those accumulate as a result of fat breakdown. Acidosis is DKA's reversed with insulin and inhibits fat breakdown. We went on that way back in like slide 2. Insulin rates can be, it's infused at a really slow rate. It's regular insulin is what you use. Generally, and just example, it's really slow, like 5 units per hour. It's just a slow drip just to slowly bring down the blood sugars. We've talked about it so times. Our hourly blood glucose levels are going to be measured. When blood glucose reaches 250 to 300, the solutions are given. D5 normal saline are we heading just to avoid the rapid drop of blood sugars. Okay, like I said, too rapid of administration of IV fluids and a rapid lowering of serum glucose can lead to cerebral edema, so you got to be monitoring that. Remember, regular insulin can only be used in insulin for approved for IV use. And what you want to do is there's a lot of drug calc in DKA when you're treating them, and there's going to be converting hourly rates of insulin infusion to IV drip rates. So the insulin is often used separately from the rehydration solutions, because as you're adjusting, generally there's an order set where you're going to have a total volume of fluid, and one set of fluids is going to be your electrolyte fluids, the other one's going to be your dextrose, and then you'll have your insulin running as well. And as you check your lab values every hour, you're going to have adjustments of decreasing your dextrose, increasing your electrolytes, or vice versa, depending on what the situation is, or adjusting once the insulin's at a certain point. Once you get to a certain point, then you decrease the insulin some more. So there's a whole flow chart that is followed by the physicians on treatment of DKA. And the insulin infusion is continuously until subcutaneous administration of insulin can take place. So you're going to keep them on an insulin drip until they convert out of DKA, and you convert out of DKA when you're no longer acidotic. And remember, way back in the time, we talked about the ion gap. This is where you need to learn about. This is where application of the ion gap comes into place. So as the ion gap closes, you're no longer in acidosis. Your pH is normalized. They will then give you your Lantus, or generally your long-lasting insulins, to get you transitioned over. Then you'll eat a meal where you'll get your regular insulin, and then that's when you've converted over. And they'll turn off the insulin drips, and then you'll monitor blood sugars, usually every Q2 at first to make sure, and following your ketones. So, like we said, blood glucose levels are typically corrected before acidosis gets corrected. Like I was just saying, sometimes we're monitoring the ion gap as you void out the ketones, and that's the other trick, is as you're rehydrating, you're voiding the ketones out. That's how you get rid of them. So with a patient, if they're possible, having them drink water and helping them void off, and it'll help progress this as well. During treatment, generally bicarbonate infusion is to correct severe acidosis is avoided. It can cause sudden decrease in potassium levels. Continuous insulin infusion is normally enough to reverse DKA. All right, so that was going through DKA, through the treatments of it. Like I said, a lot of it is basically rehydration, monitoring electrolytes, starting a drip of IV insulin and your electrolytes, and slowly reversing it. HHS is a life-threatening syndrome that can occur in patients with diabetes who are able to produce insulin to prevent DKA. Like I said, these are your type 2 diabetics. These are the ones that are, like I said, so they still are able to they're able to utilize some insulin, so it keeps off the DKA, but their blood sugars are still going up due to stress, due to whatever, and their body still can't handle that. So then you're still going to have the DKA, you're going to have the hyperglycemia, you're going to have the osmotic diuresis, the extracellular fluid depletion. It is less common than DKA. It occurs more often in adults 50 to 70 years of age who have no known history of diabetes, who have type 2 diabetics, or who have type 2 diabetics. This is something that affects primarily type 2 diabetics. So, like I said, hyper-HHS is a lack of sufficient insulin. Ketosis is minimal or absent. Hyperglycemia causes osmotic diuresis, the loss of water and electrolytes. So some of this is the same that we've talked about from the other, that we talked about through DKA. You're still going to be losing a huge amount of fluids. Manifestations include hypotension, dehydration, tachycardia, right? Because they're dehydrated, these things. Neurologic signs can cause cerebral dehydration. And then, there is a high mortality rate, just basically because if you look at generally the adults, the population that it more often affects, the 50 to 70-year-olds, those are the ones that are going to be more at risk as well. It can be traced to infection, illnesses, medications that, like your thiazides, exacerbate hyperglycemia. Dialysis can trace to. Common causes, like I said, so infections, any things that make your body need more glucose, UTIs, pneumonia, sepsis, acute illnesses, or if you're newly diagnosed type 2 diabetic and you're not managing properly. HHS is also related to impaired thirst sensation or a functional inability to replace fluids. So we talk about this in the elderly, right? They lose a lot of the elderly loses their thirst drive as well. So they're not going to feel it when they're as thirsty. Can occur in type 1 or type 2 diabetics, more often in type 2s, like we talked about. Ketones don't generally occur in HHS. Because patients have ketones related to GI symptoms, because patients don't have ketosis, they generally don't have GI symptoms, because DKA is where you're going to get, your acidosis, your metabolic acidosis is where you're going to start seeing a lot of the GI concerns. Generally, they'll notice the patients will just be, I'm thirsty and I'm avoiding more, until they start having neurologic changes. Manifestations, you're going to have hypotension, right? If you're dehydrated, you have hypotension, dry mucous membranes, tachycardia, and then depending on the progression, variable neurologic signs. Assessments and diagnostic findings, you're going to be checking electrolytes, your CBC, serum osmolarity. Blood glucose can be anywhere from 600 to 1200. Like I say, it doesn't come up as fast, but it gets higher because it's not noticed as quickly. You don't have the same, emergency of acidosis like in DKA. Mental status, like I said, and way back here, saying usually an underlying illness is what prompts them to seek medical attention. So, mental status changes, those are things they're going to be starting to notice, and that's what's going to bring them to the hospital. Like I said, it still occurs in older patients. Important things to consider is cardiovascular, right? They're going to be more cardiovascular problems, pulmonary problems, kidney function. You're going to have to monitor your fluid volume and electrolyte balances closely. But the number one trick is rehydration. Generally, there's going to be some insulin administration, monitoring fluid status, and then teaching the patient to check your blood sugars, diagnose and management of diabetes. It's just basically you're going to teach. The treatment is similar to your DKA, right? You're going to assess, promote skills to take care of them at home. Fluid treatment starts off with normal saline, half normal saline. You may need hemodynamic monitoring, BP, CVCs, pulmonary artery pressures. Potassium is added to IV fluids when there's adequate urinary output, and that's guided by continuous monitoring, frequent labs to determine potassium levels. Notice a lot of these things are flowing the same pathway. It's rehydration, monitoring electrolytes. You don't need, insulin plays a less important role in treatment of HHS because you don't need to worry about reversal of the acidosis. And a lot of times it's getting them over whatever illnesses or whatever's causing the increase of the glucose. If the patient is dehydrated, insulin is still given, but at a continuous low rate to treat hyperglycemia. The DKA blood glucose levels reach 250-300. You're still trying to avoid the rapid drop of blood sugars. So like I said, it could take 3 to 5 days for neurologic symptoms to clear. So like I said, as neurologically your brain is dehydrated, and as your fluids and you're starting to reintroduce fluids because they're coming back slowly, it's going to take some time for everything to clear and be back to baseline. Like I said, frequent self-blood sugars is important to prevent reoccurrence. So teaching the patient how to check blood sugars, medical nutrition therapy. So if they proper diets, oral anti-diabetic medications, insulins may not be needed once acute hyperglycemic complications are resolved, depending on the patient. A lot of patients, as they progress from type 2, they will eventually have some form of type 1 or reverse. If a type 1 diabetic, as they get older, generally, they will begin to need oral anti-diabetic medications, moving them into like a blend of a type 1, type 2. And that's the end of the diabetic lecture. Here's my links to my email address and my office hours. If you have any questions, you are free to reach out anytime.